Welcome to this edition of Compassionate Conversations. My name is Lynn Flanagan and I'm the CEO with Ancora Compassionate Care. Compassionate Conversations is one more way that our organization strives to connect with, care for, and support the community that we serve. Joining me today are two of our wonderful nurse practitioners, Rhonda Lucas and Lunt. Thank you so much for being here.
Thank you for having us.
Yeah. Got lots that we're going to talk about today. We are going to dive into our organization's serious illness care program. Lots to ask questions about and dissect. But before we do that, Catherine, what would you like our listeners to know about you?
I'd like the listeners to know that I enjoy my work very, very much, and I am just very pleased to be a part of this wonderful organization and in this palliative care program. And I find great joy serving my patients as a nurse practitioner and helping them to live a better life.
Wonderful. Well, we are grateful to have you part of the team for sure. So, Rhonda, what would you like our listeners to know about you?
Well, I have been a nurse for almost 40 years. I know I don't look that old.
You started when you were 12.
But 30 of the 40 years have been in end-of-life care. And I feel like that this is just the perfect way to do my last few years of my career in the serious illness program. As a nurse practitioner, I get to do those things I always wanted to do as a nurse. Actually help people with pain and answer their questions about what the next step is. And so I'm thrilled to be here, and I'm thrilled to be back at Ancora Compassionate Care.
Well, we are grateful that you are here. So, you know, one of the things you just said, how awesome. So if you feel called to do what you do and something that you've always wanted to do. You know, I have been a nurse for a long time too, and I think there's something that all three of us share is that connection with the patients that we serve, and not only just with the patients, but with the families. And that's one of the things I think that is beautiful about this program as we start talking about it is that, yep, we certainly are focused on the patient, but it does on a lot of levels involve the entire family as a unit.
Oh, yes.
So, but let's just talk about the name of it first. So we call it serious illness care. Other places may call it palliative care. You've had a lot of experience in hospice care, but how would you all describe the difference between hospice or end-of-life care and palliative care or serious illness care?
Well, a lot of our patients are at end of life, reaching that last year or so of life. We have some that we don't know because nobody really knows, but they have chronic illnesses, and that's really the difference. You know, for hospice, their doctor or their primary care provider has said, if everything continues the way it is right now, you will probably not be here in 6 months. And so that's when they refer to hospice. But there's a lot of time before that. And so that's where we come in, because there may be symptoms, and it could be a cancer that's going to be cured. But in between the diagnosis and the cure, there may be symptoms that their provider, whether it's an oncologist or a heart doctor or their lung doctor, that they need extra eyes and ears on them to keep them out of the hospital, keep them as well as possible until they are truly at end of life. But that's what I see as the difference, as we lead up to maybe not. Maybe they get better and we discharge them. But that's how I see the difference.
And I agree with Rhonda. I feel like we established a very close relationship with our patients and their family members. We also can provide education to them regarding the things that are bothering them or their symptoms that are keeping them from enjoying life right now. We can also review any type of testing or imaging results that they may have undergone. We can explain things to them after they've been to the physician for the original interpretation. And I think that that helps them a lot to know that our best interest is in caring for them and to helping them feel the best and live the best quality of life that they possibly can. And I also enjoy that with our patients.
Yeah, that education piece is just so important, because a lot of times people get diagnosed with things, or and their doctors or any other their health providers don't have the time to really explain in depth. But we're in there every month or every 6 weeks or every 2 months even, you know, depending on their condition. And so we can just expand on our education from the last visit to the next until they understand what's going on.
And one of the beautiful things about this program is our close relationship with all of their team. They're all of their providers, so that each one of them knows exactly what the patient is wanting and wishing in regards to further care.
So what I'm hearing is it's an awful lot of focus on quality of life. And a lot of times, of course, that comes right along with symptom management, right? That makes sense. But when you talk about the time to get to know the patient, what's important to the patient, that makes me think of what we call goals of care conversation, because it's really not about us or what we want, right? It should be exactly what the patient is hoping to achieve, because their quality of life is going to look very different from ours. Their symptom management is going to look different from anybody else's. But one thing before we dive into some of those conversations, where are you having these visits most of the time?
They usually occur in the patient's home. Yes.
So that makes this program unique right away.
And very valued.
I think so, but tell me why you feel that way.
Well, because a lot of our patients are debilitated in one way or the other. It may be that they're so short of breath that it's hard for them to even go to the bathroom, much less go to the car and get in the car and then get out at the doctor's office, or it may be that their pain is just controlled, but any outside, exertion makes it worse. And so when we come into the home, number one, we're able to see them without them coming to us. Now, we have a clinic, and if they are out and about comfortably and they can come into our clinic, that's wonderful. We see them there. But if not, we always do the first visit at home, because that way you get to see the real person. And I've been telling people this for years, but people dress up and clean up to go to a doctor's office. But we see them in their own element, in their PJs, at their breakfast table.
In the bed.
And sometimes people were saying, well, I don't want you to see the house. I'm like, I don't care. I'm here to see you. And we remind them that they are in control of their decisions. I tell people, you're the captain of this ship. And so you're the one that's going to decide which way you're going to go. And people like that autonomy. I think they like being reminded that they really haven't lost control
And I would think, because a lot of the conversations that you all have may not be the most comfortable conversations that somebody has ever had, but how much more comfortable would it be, to be in your own space, again, maybe still in your PJs, whatever they're comfortable in. I would think that almost gives that conversation a leg up, if you will, because you're not having to get out, go somewhere, maybe in a strange environment. You get to stay in your own spot.
Not a cold and sterile environment.
That's right.
It's warm. Their kitty cats or their dogs on the couch with them or whatever, and after we go a few times, we become part of the family. That's what they tell us.
Right.
And that trust relationship is built up, and we can almost talk about anything from that point. Now, at first, when we bring up the conversations, often, would you say often it's a little uncomfortable?
It is. I think it, of course, it would take anyone off guard to say, hey, let's talk about your goals of care regarding end of life, or the goals of care regarding what your plan is for the future right now. especially if they've been diagnosed with some sort of new illness. It could be a new COPD or chronic obstructive pulmonary disease or heart failure diagnosis or cancer. We have a good mixture of all of those patients. But to be diagnosed, to be in the hospital, to come home, and to not know what to do next, I think that we feel a large void for patients between home and going back to their doctor. And we take the time to bring up things such as, you know, resuscitation or no resuscitation, as well as things that they would like to have done in the event that they ever have to go back to the hospital. And it's patient driven as to whether anything is completed that day or if it's just, here you go, read it. One of the biggest benefits, I think, is that it helps to create an environment of how to bring it up for those families that have not talked about it before.
Which is common.
Yes.
I'm sure it is.
Unfortunately.
Yeah.
But,
and it's hard, and it's
it is
uncomfortable.
hard.
So we know because we're in it every day, but our healthcare system can be extremely difficult to navigate. I mean, really, even if you have a healthcare background, I can't imagine if we didn't have the knowledge that we do just because of what we do for a living. And there are far more people that don't have that background than people like us that do.
And of course, Catherine and I, we can't be that to all people that
Right.
we have, because we have, you know, 75 to 80 patients apiece.
Sure.
But we have a great team that is associated with us that they call themselves Care Ally, and that's truly what they are. They're our ally in that person's health care as we go along. There's nurses, there's social workers. They make calls for us in between our visits. If we have issues that need to be addressed, like healthcare power of attorney, or mom needs more aid service, we can't do it all. How do we? And then the social worker can help with that. Plus, we have some here, you know, in the agency here that can help in person. But just to have that telephone alliance, and where they have that extra support, we didn't have that last year.
Right.
Before last March, and so it has been a great asset to us, so that we can actually see more people and they're connected between our visits.
Sure. And I think that kind of support, that was actually very, that was a lot of innovation as far as our organization is concerned that we had not had before. But you're right, having the calls in between, whether it's from the RN or from the social worker, maybe you all have started a new medication, let's say. They can call in between and help you all follow up. So that has enabled us to support so many more people here in our community than we could otherwise, because you're right, you can't be but one place at one time and can't see but see.
And there's so many needs.
Absolutely. So let's just kind of walk through, let's say we've got somebody who has a brand new diagnosis of heart failure. And so now we've gotten a referral. So this is a chronic condition. Just touch on what would that first visit look like when you all go to the home?
They will always receive a phone call, most likely from our intake coordinator, to advise them that this referral has been placed, whether it be from discharging from the hospital or their primary care provider or one of the specialists. And once that is set up for us to come in and see them, we go to the house. The appointment initially is approximately an hour, maybe more than an hour. We go through what the program is all about, as we have explained here. It's essentially the same terminology.
Sure.
We review with them, or at least I think both of us, we review with them, you know, what it is that they are going through right now. If it's a new heart failure diagnosis, I want them to tell me, what do you know about what you have been diagnosed with? How are you managing it? What are your needs? What are the things that you're experiencing or feeling that are keeping you from living your best life? And they really open up and they let us know. And we're able to help fill in those gaps where they don't understand. There's also a lot of next steps that have to occur. And we're fortunate in that we know a lot of the supporting agencies around here to know what the next steps probably are going to be and who are those people on the care team, the home health agencies that are going to be providing things. Mm-hmm. Care Ally, of course, always provides a wonderful benefit if we need any help coordinating extra services or getting in touch with any of the other providers on their care team. Another part of the visit is basically the most uncomfortable one regarding goals of care.
I start out the conversation with everybody the same way. That uncomfortableness, I kind of want to just acknowledge the elephant in the room. And so I'll say, okay, now we're going to talk about, I have a small conversation here, as long as you're willing to talk about it. And you stop me if you're not. I've never had, because and I said, we're going to be open and honest here. I want to know how you feel about these things, and I'm going to approach it with love. I don't always say that to them, but that's in my heart. That's what I'm saying. Mm-hmm. You know, it's all in approach is everything. And I'll say, so what if one morning you didn't wake up and your heart had stopped and you would stop breathing? Would you want your wife, your son, whoever would be to find you, would you want them to call 911 so CPR is done, you may be shocked and a tube down, and then when you get to the hospital they will automatically put you on a ventilator unless there's something that says not to? And a lot of people say, no, I don't want any of that done. Please just let me go. And then there's people that say, oh, I want to live till I'm 100. Mm-hmm. I had a lady tell me that last week. And I said, okay, all right then. What about between now and then? If you still want to go to the hospital if anything's wrong, yes, some people say no. Right. But more so than not, people will say, well, if I fall and get hurt or if I get a bad infection, yeah, I do want to go and get IV fluids and IV antibiotics. A lot of people don't want a tube feeding, but all those things are addressed on a MOST form, M-O-S-T. And it's a state-recognized form where they can take it with them to any emergency room. And without even asking a question, the provider knows what to do and what not to do, which how much pressure that takes off the family. Because sometimes they may be 15 minutes behind.
Right.
And if it's not sent on with the EMS, then everything's
They've
done
got to do whatever. Yeah. Mm-hmm. And, you know, that is such, you're right, how much pressure that is taken off. But when families can know, you know what, we did exactly what mom wanted or whoever their person is, that right there is
just a gift.
It is an absolute gift. But back to what you said earlier, because this is certainly not a slam against primary care providers here in our service. We've got some fantastic providers, but there is not the time to have the conversations that you just described, because that's not a 5-minute conversation. It might not even be a 1-visit conversation. I would imagine as things go down the road a little bit that some people may change their mind, or maybe, you know, I didn't want to talk about this last Tuesday when you were here, but I've been thinking about so and so and so. So just you all helping to navigate here where your choices are, but then not making the choice for them. It's obviously the patient's choice. But how many wonderful seeds you all have planted just within that first visit to help that patient and family think through, you know, what would I want done? We probably would be surprised as to how many people have never stopped to really think about that.
Well, you know, the generation of letting the doctors and providers do whatever they wanted to them is passing. Mm-hmm. And so, and the baby boomers are coming in and they want more control over things. And so what a great opportunity to remind them that they do have, you've lost control. If you have a heart failure diagnosis or cancer, you've lost some control. But if you can maintain this, and like I said, give that gift to your loved ones, where they don't have to be barraged, you know, with questions and not knowing what to do. a lot of times too, and I think Catherine probably does this as well, is maybe they don't know right then, but they have siblings or other family members they want to involve in the decision making, like if mom or dad can't. And so they can take that empty form, that blank form with them and show it to the other folks, because it's pretty self-explanatory.
And then they can have that conversation.
And then we can come back and have the conversation.
And I believe, I'm sorry, I didn't mean to interrupt you, Rhonda. I believe thoroughly that when I have the conversations in the home, I think something that really registers is when I say, when you pass away, where do you want that to occur? Home, hospital, nursing facility? The majority will say, I would love to be here at home. And just saying that really helps to guide them with the thought process.
I'm sure. And you know, again, if there was some way we could track it, I wonder how many times when somebody answers your question that's the first time somebody else in the room actually heard them say it. That would be interesting to know. So what I have heard is a tremendous amount of coordination as you all are caring for people, as you're getting to know these patients and their families, as you're having these conversations. So we've talked some about Care Ally being part of our team, but we've also touched on the fact that whether it's Care Ally helping to coordinate that, or you two, getting connected with other resources in the community. So I'm hearing a lot of coordination and a lot of support. Tell me, how do you take all of this back to that patient's primary care provider?
Well, certainly we can call them if they are in a healthcare system, that we have access, provider access to both Baptist or Atrium, UNC, and Moses Cone. They call it EPIC, which is like the people have My Chart at home. Well, this is the side of the care side, the provider side. We can go in there, look up their records, because they give us permission on admission to coordinate care. And half of that is really knowing what's been done already before. And then we can communicate through that, which is my favorite way, because calling offices, they're so busy. And it's hard to get back with them, especially if you need an answer right away. That's one of the ways. And then if nothing really is going on and everything's, at this point, the person is stable and their symptoms are controlled, we always send them a copy of our note from the visit that we do in the home. And that goes back into their medical record at their provider's office. And sometimes if they have a specialist involved, we send it both places. Depends on who's involved in what. And they really appreciate it. The oncologists here really appreciate our ability and our willingness to help their cancer patients with pain. The pulmonologists were keeping their patients from going in and out of the ER. People, if you go to the emergency room with COVID and RSV now and the flu, they may come home with more than they went with. And so we try to keep them out of the hospital as much as possible, whether it's just an ED visit or certainly being admitted, but we try to keep them at home. And so we can call those providers and say, hey, what do you think about doing this and this, to keep them at home. We don't do it. We do what's related to what we're seeing them for. So, but again, that's symptom control.
Go ahead.
We've had several patients who may not be feeling well on a day that we're not visiting, and once we're notified, we would encourage our patients to call the Care Ally line to speak with the nurse or the social worker, and they always report back to us on a daily basis how all of our patients are doing via secure texting setup. And if someone is sick, not feeling well, and perhaps they've tried to get in touch with their primary care provider, let us know. Our Care Ally team can work behind the scenes sometimes and get a same-day appointment or a telehealth visit for them, so that it would avoid an ER visit.
So all of that coordination and support, that would be the ultimate goal. But if you are the patient think how wonderful that would be to know, hey, Catherine came to see me today from Ancora Compassionate Care, but I know she's going to be talking to my Dr. ABC over here because they're working together on my shortness of breath, let's say. That right by itself
and the
is
providers,
comfort.
The primary care providers and specialists appreciate it too, because they can't be all for all people. You know, they can't take care of everybody all at the same time. And people, especially this time of year, people are so sick with respiratory diseases and other things. And our folks are fragile. It doesn't take much for them to get sick. And so knowing that they've got another extension of themselves. I actually had a physician tell me, he said, I'm not seeing her as often as you are. He says, and I really appreciate the fact that you can monitor this. You know, it was a new pain medicine, and he wasn't going to order it because he didn't feel comfortable. He couldn't monitor that closely. He says, but I know you will. And so he says, you know, I would like for you to take care of that for me. So we're an extension of them in that right. But people really appreciate it. Home health can be in that same home with us, not so on the hospice side, but with our program, they can be in there too, helping with the most acute issues and therapies.
Right.
Yeah. And I think that's an important distinction. Yes. You know, when we talked earlier about I guess at the beginning of the program, the difference between hospice and palliative care. And of course, with the Medicare guidelines with hospice, all aggressive treatment has been stopped. But that is not true with palliative or serious illness care.
That's exactly right.
Yeah, if they have home health going on, they're still getting chemo, radiation, but you all can be in there at the same time.
Right.
That's right.
Yeah. Exactly.
We've been talking a lot about lung patients because we do have a lot of those, but we actually have patients who choose to have a machine that helps them with their breathing that's considered aggressive. So we can still have those folks and still make sure that they stay as healthy as they can and comfortable.
So one thing that is near and dear to my heart that I want to talk about symptoms. You know, typically when we talk about symptom management, it is pain, or it might be shortness of breath. Maybe it's nausea. But, you know, I'm an old mental health nurse at heart. So I never want us to miss the opportunity for people to understand that symptom management might also be not sleeping well. Maybe it's depression. Maybe it's anxiety. But if those things are not controlled, it would show up physically, right?
Yes.
Oh, yes.
We do take a holistic approach when we see all of our patients, and they can also be lonely in the home. So that again is another benefit of Care Ally. They can find ancillary services for pretty much whatever the need is for that patient at that time, whether it may mean they need to see someone in behavioral health, whether it means, hey, we need to get in touch with their primary care provider because we're seeing some signs of depression and maybe they need to get started on some medicine. We even have mental health, Hunter.
Yes, we have chaplaincy that since the beginning of this program here, he's been available, or Hunter Thompson, one of our chaplains, has done the majority of it. But they have been able to visit. But we're excited about the opportunity that we have maybe to do some behavioral health in the future, and I won't go all into that, but because it accompanies it.
Absolutely.
Whether they had it before they got sick, or whether being sick is making them depressed or anxious, it's a part of it. And we may use medicine, but a lot of times the ancillary, like she was saying, just having either spiritual. And I'm finding that during COVID, a lot of people stopped going to church. And although they may be a member or they went to that church for years, there's not that connection, spiritual connection anymore, whether it's church or synagogue or whether just a faith community of believers. But they don't have that anymore.
Right.
They may accept chaplaincy, but they may not. And if they don't, that's okay. We offer it.
Right.
If we try to assess all that on the first visit.
Right. Sometimes we're just an ear. They may not have symptoms that we can see, that we can touch, tangible, but we can listen.
Mm-hmm.
And, you know, that just having someone listen to you,
Or the
even
family,
for 5 minutes,
or the
helps
family
a
gets you
lot.
to the side and says, she's not sleeping. She'll say she's sleeping because especially the
Right.
older folks, they don't want to admit they're having any problems.
Right.
Exactly.
But caregivers need that support
They
too.
do.
That's what I wanted to mention. Families don't really know where to turn a lot of times.
Exactly.
And so them having somebody just a call, you know, that's what they'll say. I just can't get over how much better it is having you and your agency, because now they can call Care Ally or they can get a nurse on the line 24/7.
24/7.
Yeah.
And that alone is just a breath of relief, I think, for a lot of folks.
Well, I think it would have to be. So if you know you've got that support that, hey, somebody is a phone call away. Because maybe it might be a very simple question. Maybe it's just a quick conversation. Or maybe it's, hey, we do need to get this person back to their primary care provider maybe sooner than we thought. Or all the other things that you all have described. But before we call 911 and we've got to go to the ER, maybe we can handle it right here. So it's quite a unique program. You all do an awesome job. I'm thrilled that our organization can bring this program to the community. I think there's so much potential within this program. You mentioned behavioral health, and that is a little baby pilot within this program. But what a fantastic resource as we learn more and we're able to roll this out. I think it's just going to get better and better. If there was one thing that you really want the primary care providers in our community to know about this program, what would you tell them?
Do you have folks that call your office a lot? Or that show up in the ED a lot? Or want to make an appointment to come in? And a lot of times it's about questions or about symptom management. And it can be from the time of diagnosis. I think sometimes that's misunderstood because when they think palliative or serious illness, they think that it's just a little bit before hospice, and that's not true.
Right.
And some people, you know, outlive and get, you know, have cures, like if it's cancer, have cures or whatever, or they can live for years. But I say if you have someone who is constantly calling, frequently in between visits, or you need some support for your patients, or you see a caregiver having a hard time, please call. Or if you need somebody that you're not having any headway or haven't had time to have any headway with those goals of care conversations, give us a call. Because we have had a couple that we just went out and basically had the care goal conversations with them and got advanced directives in place, and we pulled back out because
That was kind of all they needed at the time.
yeah, and that's okay.
Yeah.
Because who are they going to call when they really do need somebody? Hopefully it will be us.
Right.
And we want to partner with the physicians. We don't ever intend to take their place. And we really advocate for our patients to continue going to see the primary care provider because he's essentially the gatekeeper as well as all the team members that surround that patient. Our scope of practice being a nurse practitioner is different than being a registered nurse because, you know, there's two different things each discipline is looking for. And when we go into a home, you know, we are truly evaluating every single piece of medicine that they're taking. We're looking to see how they're handling any kind of exacerbations or what are you doing day to day. And sometimes it's literally as simple as maybe not having the equipment that they need or not knowing that they can have a refill on a medication or not having a nebulizer machine, honestly. And you know, those things are taken for granted, I think, in the busy world of emergency room and in primary care provider, or maybe they did have one and it's old. So those are the real wins, I think, is when we get in there and we can really help manage someone's symptoms. And then you hear them say, I went to church. I went to the grocery store.
Right.
I slept good last night.
Yeah,
That is
where you
music
know
to
that
us.
quality of life has been achieved.
Exactly.
Even it may not we may not think that, but to them, from where they were, that's a huge jump in their quality.
Right.
And so that's what it's all about.
And then you can have the other side of it too. It as we're in the home, if that person starts to decline, we usually can tell. We notice something, and we can then begin to change our conversation if that's what the patient's care plan says,
Sure.
to help them ease into or understand what is happening to them and when we may think it's time to bring hospice on board, as long as that was with their plan of care.
Sure.
And, a lot of our patients, we're hoping to get them at that point of transition a lot earlier so that they can then enjoy the benefits that are associated with hospice. So it's a win-win, especially for the patient and the family, and they can hopefully proceed with end of life with quality and dignity that they wanted.
And it's a win for their primary care provider, because with you all's support and the support of Care Ally through our serious illness care program, they truly can coordinate and provide the best care for their patient all the way through.
Exactly.
But I do not want any primary care provider or specialist to feel like they have to wait to pull us in. Right. Because most palliative care or serious illness programs say 2 to 3 years, prognosis, and that's somewhere in there is the appropriate time. And so we don't want them to wait till they're already in the bed, or we want to get to know them while they're still them.
Exactly.
And they're still.
And I think the key word to that, though, is quality. That's what I always go back to in my mind. That what is quality to that patient, and how can we help them maintain that for as long as possible? And I think the earlier this program can get in, the better chance that
Education is a big part of that.
Sure.
And recognizing when they aren't able to do what they used to be able to do. Right. And that's when it's time to start thinking about maybe next steps. Or I tell families, what's plan B?
Right. And so as we wrap things up, one thing that I would like the community to know is certainly we do get the doctor's order, whoever their primary care provider is, but anybody can pick up the phone and call them and refer themselves even to this program, right?
A lot of our referrals are that way, come through not only even close family, sometimes it's just somebody that knows somebody, and they'll suggest to the
or they have services themselves, and they say, look, I have Catherine and Rhonda coming to see me, you should call. So they're like, well, I think I will, and then there you go, word of mouth. So it's
and insurance does pay for it. If they have a specialty copay for like their pulmonologist or their heart doctor, then it would be the same for us. But of course, we don't. Catherine and I don't really get involved in all that, but we do have to let them know that on the beginning.
And all of that would be taken care of prior to your visit anyway.
Exactly.
Right?
Exactly.
Yeah. So we would.
We have a really good intake team, and billing that works behind the scenes before we go out. And then more as of late, we have a nurse or a CMA who goes out into the home and explains the program so that they know that we're just not hanging out there for, a while. Because sometimes we're backed up 2 or 3 weeks before we get out. But it's a great program and such a benefit to our community. So,
well, thank y'all so much. I appreciate your time and being here. Thank you so much for joining us for this edition of Compassionate Conversations. If you ever have a question or you would like to learn more, maybe there's something that you would like to see us talk about here on this podcast, you can always call us at 336-427-9022. Feel free to find our website at www.ancoracc.org. And again, if you have a question, you can actually email us at info@ancoracc.org.